Welcome back to our discussions on the quality of reproductive, maternal, and newborn care in India.
Before I start the slides, I just want to say that we feel that this is an extremely useful approach because it can capture things that you can't just answer with a yes or no question. It gives you a lot of context. It puts things in the actual words of the actors who are in the room, which is very rich. It also captures things that are completely unexpected that you might not have on your quantitative observation tool. So you might not have a line that says, you know, were birds flying in and out of the open window? Yes, no. You know, how many people wandered in and out of the room while the woman was undressed? I mean, you might not actually have a way to capture this in a checklist. But if your enumerators are properly trained and are very attuned to this, then they can capture a lot of these things in their open-ended comment section. So the analysis, before I start the slides, the analysis is still ongoing to capture how many women, we know how many women experienced one level of disrespect, but what we're doing is now looking at how many women experienced one, or more than just one. Let me see. So there were 26 nurse enumerators, and they observed about just under 1,000 births, 892 births, in 38 districts in Bihar, and this yielded about 2,800 comments. And there was thematic analysis of these, and about 1,200 were relevant to respectful maternal care. Kaveri mainly used the Boren's typology of respectful maternity care. This is just a table which repeats the earlier slide. So this is a very brief summary of the treatment. You see, for example, that privacy was provided in less than half. There's a not unsubstantial amount of verbal abuse, about 10%, also physical abuse, and rather low levels of questions being answered or encouraged, or any explanations. So this table right here, this is not, the findings on this table do not belong to the same denominators as the other one, but I'm just showing you because this shows you the kind of questions that you get on a questionnaire that won't necessarily yield the same somewhere on your quantitative checklist, because it's a real opportunity to catch things that you can't catch otherwise. And a real opportunity to, if you catch things that are completely unexpected that you wouldn't have put on a checklist, then that's an excellent opportunity to address those. That's it. Thank you.
All right, so we'll save a couple minutes there. Thank you. I wanted to, if I can, just for a second, and you can. One of them was quite an artist, and this is actually a sketch that she did of her many, many hours observing births, and this is an image that she put together, and I think this is quite powerful because this is recent. This is Bihar, and Bihar, like all other states in India, like honestly every other country in the world, is really starting to understand this problem better and hopefully innovate to create solutions. So with that, we do get to move a little bit to the idea of solutions, and I want to welcome Dr. Shalini Singh to the podium. We are going to hear hopefully a bit from her. She is a obstetrician gynecologist with the Division of Reproductive Biology, Maternal and Child Health, Indian Council on Medical Research, Department of Health Research. And here, and sorry if I mangled that rather long description of your organization, but what I'm hoping you can share a little bit with us is how medical colleges are starting to address and incorporate solutions to this problem. So thank you for joining us. Is the last one? Oh, okay, all right. So it's good to go back and forth.
Yeah, so good morning, and thank you, Sunita and Priya, for inviting me here and to share my organization's work in the area of respectful maternity care. So we started quite some time ago in 2015 when we had a task force on respectful care, and we started brainstorming as to how to collect this data, because There were reports from across the world, but not from India at that point in time. And our organization mostly works with the medical colleges, and then, of course, later also with the district health system. So we thought that since in the medical colleges there are nursing colleges as well attached to them, and for respectful maternity care, we thought going into the pre-service, part of their training, that will be most helpful in seeing how they form their ideas and how they then practice it. And then later on also, the pre-service training of theirs will translate into the in-service behaviors. So with that, we started out with engaging with the medical colleges, and we asked them, whether they're willing to be a part of the study. Yes, most of the obstetricians were the heads of the departments, and they wanted to be a part of the study. But they had some things in their mind, like whether I think in heart of heart, they all knew that there are things which are going wrong, but they were not too sure about a research study. How would the ethics committees react, and what would the patient groups say? Will they be sued by some people? So those kind of ideas they discussed with us informally, and then when we told them that then we had to convince them, and then we had to do a little brainstorming with them, and then still said the ethics committees went back and forth with them, saying that yes, you can do this, you can't do this. And so finally the study has started off, and we have about 20 medical colleges from all over the country. They have agreed to be a part of the study, and the study we are doing along with Aparajita's team at White Ribbon Alliance and Center for Catalyzing Change, and they have been a great source of technical support for the study. So we then we thought that let us first use the already available MChip tool and see that whether our providers actually understand what is there in the tool, and how do they then maybe may have to adapt it in the Indian circumstances. And so when we began last year with the national workshop, where almost about 75 persons attended it, including from the Ministry of Health and all the key stakeholders. We discussed the framework of evaluation with them, and so most of the providers, though they were from the obstetrics and gynae department, they wrote in their feedbacks, that they never realized that these things are, these common things are disrespectful. And then most of them would say that in the face of such heavy workload, are they really, they never really got to know. And some of them said, yes, I think we will change these, at least in our own individual practices, and try and implement some of these in their hospitals. Then I think they were more keen to participate in the study. And so what we did was we had this checklist of observations brought out, and it was based on these 7 categories of disrespect and abuse, which Aparajita already talked about. And we also introduced the FIGO Medical Code of Ethics as the guiding principles, and behind each of these 7 categories of disrespect and abuse. And so the study has started at 9 centers already, and I think slowly we will have the results come in. So in each of these 7 categories of disrespect, we have further classified them into about 8 or 9 categories of different kinds of observations. And as Karima mentioned, that qualitative remarks column we've already included under each of these categories. And so they are writing, you know, they're trying to, our observers are actually from the departments, they're not some people from outside. So they know the department, they know who's the provider, who's the doctor, intern or nurse or whoever it is. So one thing is that we thought that they may be biased, they don't want to report against their own providers. But then we said you don't have to report them by their names or individually, but just the category, like whether this was done by a doctor or a nurse, just to understand what's going on. So that was one. And then the flip side of it was that, you know, if we had people from outside doing the observations, the staff and everybody would have got alerted, so their behaviors may have changed. And it was not a very long kind of a study that you can say that, you know, they'll finally go back to their behaviors. So keeping that in mind, we trained these researchers how we did a theater workshop also for them on the second day of this national workshop, to train them especially to, they did role plays and they understood what was the concept of respectful care. And with that background, they went back to their facilities and they are now doing their observations. So we soon get the results and we'll be able to share them with you. I think the most biggest challenge is that they feel that in the face of heavy workload and infrastructure, I would say shortages, manpower shortages, they have to be able to differentiate between that and respect. So somewhere that has to be instilled, and maybe we will be able to do some bit of intervention also later. Thank you.
So I think this presentation reminds me of the absolutely essential interprofessional nature of these solutions. It's not doctors or nurses or the person who sweeps the floor. It really has to be interprofessional solutions that address this. So next, we get to move into a part of the conversation where we get to try and pull some themes together. And some of us live by metrics of how often one is cited. But I have to say, in the case of Lynn Freedman, she is not just a leader in this field, but she has been such a thought leader. And the reason why she is so well cited is because she has conceptualized a very, very difficult concept for people in a way that they can get their hooks in it and really start to address it in practical ways. So I thank you for your help in that, and I know that many of you here have used some of her guidance in the past. So with that, I welcome Lynn Freedman to join us. You may know her as the director of the Averting Maternal Death and Disability Program. She is a professor at the Population and Family Health at Columbia in New York City, sorry. She's a lawyer with public health experience. Sorry, I'm dragging this out and she's gonna kill me for it, right? She's a lawyer with public health training who has worked for more than 25 years, including some time in India, at the intersection of human rights and public health. And she engages with governments, NGOs, UN agencies to help make that happen. So Lynn, I'm gonna ask you to try and pull some of these themes together, and if our speakers can come up, then we can take some questions and continue the discussion. All right. Okay. And do you, let's see, did you have slides?
No.
Okay, got it.
Can I put this down? Go ahead, sorry. Hey, good morning, everybody. It's wonderful to be here. Let me just make a few observations. I think a first question that we have is, what are we actually measuring here? And I want to draw first from something Aditi said about the negotiation of power and control over women, in order to make the following point. Let me put this out there for discussion. I think that this whole RMC area is not just an element of quality of care in the hierarchy of needs about what we need for quality of care to survive. I think it's really important that we step back from our sort of positioning here as a health group looking at quality of care and recognize that women's experience in childbirth is a lens for many other things in their lives. So when women are lined up with their vaginas showing, this is also watching women's humiliation at the hand of the state in a state institution, or watching women's humiliation at the hands of other powerful actors in society. So I think it's not just a question of where does this fit in our quality of care map. It is that, but it's not only that. And I think it's really important for us, even when we're in a health setting, to acknowledge that, which kind of draws on Gita's intersectionality. It's also about how women are valued as mothers differentially. This is a key issue for us in the US, which I can go on about later. It's also a place where women can exercise rights. So it's not all a negative. If women are able to demand better treatment, get better treatment, and the situation changes, that's also a venue for exercising rights and agency. And so I think it's really important that we see this phenomenon beyond quality of care. The second thing, what are we measuring? I do not think there is one truth about what we're measuring, and there's not one gold standard to measure it. In fact, I think there are a few points to be made here. One, disrespect and abuse, I think, is a different construct from respectful maternity care. And in fact, the absence of one doesn't mean the presence of the other. And Karima went really fast through a slide, but I noticed that one of the slides there, if I saw it right, said 69% of the women said they were touched kindly. And what we've seen in our research is the very same women experience disrespect and abuse, also experience moments of true compassion and kindness. And so I think even that these are two different constructs, and we should not think of it as one continuum. So two different things are happening to women, or are both part of their experience. At the same time, we're measuring two different things when we do direct observations of delivery as compared to the self-report that Aparajita was talking about. And we in our work have actually done self-report from the same women who were observed. So we've observed women during childbirth and then had them report on their experience. And the prevalence of the exact same things measured in the same way with a checklist plus and open-ended are dramatically different. So in Tanzania, for example, we had roughly 70% prevalence on observation, but those very same women report like 10%. And they're reporting different things. So is one of those right and one wrong? I would argue no. There's not a gold standard, that one is a kind of experiential reporting, and the other is about norms and whether or not people have followed these respectful care norms. And I think both of them matter. They're both, it's not that one's right and one's wrong, because we need to, I mean, the protocols that people are, Aditi talked about protocols that were being departed from, those matter too. So women's experience matters, as do the implementation of protocols. I think this also brings us to this issue of women's internalization of powerlessness in this setting, and providers' normalization of poor care as they're being measured for during the observation. So when it comes to that, I just want to make one very brief point, which is I also think we should not see this as an issue of individuals run amok. So several people yesterday, I think Steve, I don't know where he is, and a few other people talked about drivers and getting at drivers of behavior, we've used this idea of so-called practical norms, that actually when you look at these behaviors, and Aparajita made the important observation that they seemed unchanged despite patient load. So what does that mean? There's something going on there that's not only about the stress of the moment. So there's some, I think that through empirical research, you talked about it in terms of drivers, but I think we can do empirical research to get at unwritten, informal norms that are actually regulating behavior. And until we get actually to documenting and understanding the way those unwritten norms work, I think the training, et cetera, of individuals, even the suing of individuals, honestly, is not going to be an answer. And so then I would just make a couple points that are principles that we've used for trying to think about interventions and also research. So one, no provider goes into this field to abuse people. That's really clear. And I think it's really important that we have what I would call a 360-degree view of what's happening here, that we understand what's happening to women, but we also really try to understand what's happening to the providers who are working in difficult settings, that this becomes either because of role models or whatever the reason, this becomes the norm that is actually informally regulating their behavior. I think also the lessons from the social accountability work, including White Ribbon's work, are that we can't just work at one level on this. In social accountability generally, I think there's a real understanding that just giving people voice doesn't create real change, that we need to work at multiple levels and in multiple directions to solve issues like this. You know, and finally, I think there's, the literature tells us in a way there's strategy and there's tactics. So I think it's really important that we have a very long-term, kind of profound understanding of how the system needs to transform and really change. It doesn't mean that it's going to get overthrown immediately. But I think as we take small steps or even bigger steps, I think we do need to be talking about what is a people-centered system really? What is really people-centered care? And how different would everything look, start to finish, if it were truly people-centered? And I think this is one of the symptoms of a system that is not yet really people-centered, even if there are moments of patient-centeredness. So I'll stop there.